everyone. Thank you so much for coming tonight, and thank you especially to our East Coast colleagues, including our speaker, for coming so late. Tonight is the inaugural American Journal of Surgery Stars Committee virtual seminar series titled Giants in the Field, and I'm Elise Fannin. I'm a resident at UC Davis, and I have here with me Lamario Williams, who's a medical student at UAB. So STARS Committee stands for the Student and Resident Scholar Committee, and its aim is to ensure equitable access to academic surgery. We're so excited to have Dr. Dechert as our first giant in the field of social justice. Before I introduce Dr. Dechert, I'm going to give an overview of the evening. First, Dr. Dechert will give her lecture. It's about 40 to 45 minutes. After that, we'll have a Q&A session. We'll first start based on a lot of your pre-submitted questions, and then there'll be some time for any other questions that arise. If significant time remains after that, I was really hoping to simulate a social networking environment by splitting off into smaller rooms and just getting to know each other. Dr. Dechert's going to jump around to those rooms and kind of allow a more intimate interaction with our speaker. And during this time, feel free to network among each other, because I think that since we're all at this talk, we are all pretty like-minded about social and healthcare. Now allow me to introduce our speaker. So Dr. Tracey Dechert is the Chief of Acute Care and Trauma Surgery at Boston Medical Center. She completed her medical degree at Temple University, her residency in general surgery at the Medical College of Virginia, and a fellowship in the Department of Traumatology and Surgical Critical Care at the Hospital of the University of Pennsylvania. Dr. Dechert is passionate about health equity and serving vulnerable populations. And in 2014, these passions and interests led her to create socially responsible surgery, to establish social responsibility as a core value of surgical practice. Composed of like-minded faculty, residents, and students, SRS works to improve equal access to surgical care, eliminate healthcare disparities, increase patient advocacy, and educate and serve the local and global community. Supported by the 4 pillars of SRS: research, advocacy, service, and education, SRS works to bring our nation and world closer to health equity through socially responsible surgical care. Today, Dr. Dechert is here to talk about the importance of social responsibility in the practice of surgery and how cultivating a socially responsible healthcare system is a path to reduction of healthcare disparities. So Dr. Dechert, take it away. Thank you.
Hi, everyone. Thank you for coming. To say I'm thrilled to talk about this topic is an understatement. I am passionate about this work, and hopefully you will be too if you're not already by the end of my talk. But I view this somewhat as a talk, but also somewhat as preaching, because I am so passionate about it that I really want to make converts of everyone I meet. So hopefully that will be happening. Nothing to disclose for this talk, or basically any talk, other than I am a fan of Matisse. So you will see some Matisse paintings throughout the talk in critical junctures where it starts to get a little heavy, because this is some heavy stuff that we have to talk about. We'll put in some art to get us through. So these are some objectives for the talk, really thinking about social determinants and addressing more so like the root causes that contribute to poor health, really thinking about midstream approaches. We're going to talk about that a little bit, addressing social risk factors and social needs in our patients in surgery, really talk about this concept of surgical equity and its significance, both here locally and globally. And then I wanted to end with really, discussing social responsibility in the sense of what does that mean in surgery? What does it mean as a surgeon, as a surgical resident, and so forth in surgical practice? So those are some of the things I wanted to talk about in this talk this evening. But to start, I think we really have to start with, what is health? And I think we somewhat get skewed because we're in the hospital all the time, right? And we're taking care of patients. And we kind of sometimes think health is basically patients, if they do not have illness or injury, they have health. But that's not really how we should be thinking about it. Health is a state of complete physical, mental, and social well-being. And it's not the absence of disease or infirmity. So I wanted us to think about health for this talk, especially in this way, more of a structural, functional, emotional state, and how we live our lives as individuals. And then taking it one step further, so not just the individual piece, but then kind of more in a society level, the highest sort of standard of health is a fundamental right, I believe, of every human being, regardless of your race, your religion, your political beliefs, so forth, right? So I think when we talk about health, it really should mean that that's something that should be attainable for everyone. Population health is a less commonly used term, but that can be useful because it encompasses sort of the average distribution and inequalities in health within a society. Health equity. A good definition of health equity is attaining the highest health for all people. But most important, it is through the absence of systematic disparities in health between groups with different levels of underlying social advantage or disadvantage. Unfortunately, health equity remains elusive in our country, and that is despite increasing attention, that is despite increasing research on health inequalities, and even though it has been an explicit goal among federal, state, local governments, public health officials for many years, we still have much work to do. So the topic of health and surgical equity, I believe, falls into a broader recognition that social responsibility and social accountability really need increased attention in medicine. The communities, when we look at the communities most affected by poverty, racism, language barriers, communities with the largest populations of immigrants, they continue to have the worst health outcomes. And those are the things we want to talk about tonight. So why do we need to discuss this as physicians? Well, given how hard we all work, and it's 80 hours a week, right? All that work is really only 20% of health, as you could see in this graphic, right? The healthcare piece on the bottom, 20%. So 80%, therefore, of an individual's health is determined by behaviors, social, work environment, all of that, which is social determinants. While we tend to think of health in terms of whether a person has a disease, 80% is determined by this social environmental milieu. The context of people's lives really determines their health. So if we blame individuals for having poor health, that's not really appropriate, nor crediting them for good health, right? So much of it is not really under people's control. So given that they can't directly control many of these determinants of health, right? So that's why we have to think more broadly. And then ideally, if we sort of work with and for our communities that where we are in our different med schools and hospitals and residencies, right? It's underutilized as a method to provide really better care for our patients if we can think about sort of the other 80%. And then if you think, okay, well, that's medicine and physicians or primary care, but we're surgeons. Do we have to think about this? And my answer, of course, is yes. Yes, we do. Underserved populations, right? We hear that term a lot, but if you think about who is underserved, it's a huge amount of people, right? Because it is people who are homeless, people who are poor, people who are uninsured or underinsured. It's the elderly. It's people who are incarcerated. It's more recently, even more so, women, right? Like there's a huge amount of underserved populations. And as far as the surgery piece, suffer higher rates of traumatic injury, overall just kind of have worse outcomes. So we have to think about this as surgeons and talk about it because it does matter. And then if we want to look just at a snapshot globally and think of, okay, we're training to be surgeons, possibly. All this work, who gets to, be the, who benefit from the work that we do? Well, 5 billion people do not have access to the work that we do, which is staggering, right? That's just striking to think that that many people on this globe do not have access to surgery. And then if you look at who gets the surgeries that we do, poorest third of humanity, 3.5%. That's abysmal. So I hope with this slide you can see some of the reasons, just some of like why, yes, we as surgeons do have to discuss this and work on it, and of course, do better. I want to take a minute to sort of talk about some of these terms. You may have seen these slides or these graphics, and I'm sorry if you already have, but it's just important to kind of set the stage for everything we're talking about. So this is the, equality versus equity. And many times these words are used interchangeably, but as you can see, they do not have the same meaning. So inequality refers to uneven distribution of health or health resources. Health differences based on age, for example, that's health inequality. So normal, right, for the health of someone who's a young person, their health is in general going to be better than the health of an older adult. And that's inequality. Inequity refers to systematic, unfair, avoidable, keyword, right, avoidable differences arising from poor governance, or it could be corruption, cultural exclusion. Differences in health outcomes can be observed between populations, between social groups within the same population. That's equity. So here, equality, this involves treating people the same, which at first sounds good, right? Oh, everyone's treated the same, right? But you're making the assumption, which we all know, don't make assumptions, that everyone really just needs the same support. So this is equal treatment. If we want to do better, of course, we would acknowledge, wow, everyone has their own unique history, their experiences, their needs, and so forth. And then this would sort of shift from equality to equity. For instance, making accommodations for people with disabilities is based on the concept of equity. But interesting, right? Often those accommodations could be benefiting everyone. So like, for example, elevators in a building we all benefit from. But wouldn't it be nice, maybe in my lifetime, wouldn't it be nice if we didn't have to support or accommodate anyone because the causes of inequity are actually addressed? We change the system. That is a wonderful idea and thought. Hopefully we will get there someday. This is social justice. This embodies a vision of an equitable society where all members are physically, socially, psychologically safe. Our basic economic needs are met. We are able to exercise our right to basic human dignity. So when we look at social determinants, what's interesting is when I was in med school, I don't remember learning about this. Maybe I did, but I don't think I did, because SDH for kind of the longest time meant subdural hematoma. But I think now students would agree that I think it's much more, discussed in med school these days than it had been maybe in the past. So when you look at social determinants, it's not a surprise, right? And everyone sort of knows, yes, poverty has a major adverse effect on health. And that is after controlling for these behaviors that we often talk about, right? So many people will say, well, the poor person has bad health because they smoke. And not that I'm promoting smoking, but if you control for those behaviors, they still have, of course, worse health. So that's not the case. It's not about the behaviors. And so that's important. And then health behaviors, though, also are influenced by social determinants. So for example, it's easy to say eat well and exercise, but the person's physical environment, has an effect on that. So this association was first documented actually, quite a while ago in the mid-1800s. That's more recent history. I mean, the ancient Greeks, they also knew this, right? Like, so we've known this for a long, long, long time. And now I would say the term is pretty ubiquitous in healthcare. It seems like we talk about social determinants now more than ever. So I thought I'd throw a definition in here. This is the second one there is a definition from the World Health Organization. And, as we look at this graphic and the different sort of colored circles, when we think about public health interventions, right, they're often kind of on individuals' knowledge or an individual's behavior. the social determinants are trying to look at, like a broader context. So these fit within a larger context of another term that's now more recently used, which is structural determinants. And that includes governmental and economic policies. And these are priorities and therefore allocating resources within society. So I think instead of SDH, it should maybe be SSDH, structural determinants as well, right? So it's complex though. It's getting hard, right, to kind of wrap your head around all this, because these, there's social structures, economic systems that include the social environment, the physical environment, it includes health services, structural societal factors, all of that. So the social determinants of health are shaped by the distribution of money, power, resources throughout local communities, nations, and obviously just the world. And then to take it even further, political determinants of health, which you could see a definition here. So this is appreciating, right, that social determinants, it's a great word, it's a great, of course, concept, and we have to know it and think about it, but then it can miss if we don't realize that there are political determinants as well as the structural. Because this is, right, how, power is involved here and political decisions. So there's a book written by this person here, Daniel Dawes, The Political Determinants of Health. I don't expect you to look at that diagram closely and figure it out, because even when I did, I couldn't quite, it's pretty hard, but when you have time, you could always look that up and look at it more closely. But basically, the political determinants of health create the social drivers, right, including poor environmental conditions, inadequate transportation, unsafe neighborhoods, lack of healthy food options, all of that affects all sort of other dynamics of health. So social determinants, structural determinants, political determinants, all related. So also when we talk about social determinants, we sometimes act as if our patients have them and like we don't, which of course is ridiculous. We all have social determinants, everyone. You can't not have them. And inherently, they're not positive or negative in and of themselves. So social determinants also are a little different when, like we were saying in society, whereas the work we do every day with our patients, that's where we're maybe really addressing more social needs of the patient. So a good example is if a patient does not have access to food. At our hospital, we have a food pantry. So, right, patient X does not have access to food. We can write a prescription. They can go to the food pantry and get healthy food, fruits, vegetables, stuff grown on our urban farm on our rooftop. So that's wonderful. But wouldn't it be more wonderful to have a system where no one is hungry? Like you don't need a food pantry because we address the underlying systemic issues that cause food insecurity in the first place. And this idea kind of gets to the upstream, the midstream, and kind of downstream. You might have heard those terms already, but right, so the upstream is operating at kind of more the macro level, where it's like social structure, culture, large institutions, government policy, all of that is like upstream. So examples of that would be like the education system, systemic racism, juvenile justice system, things like that. Then there's midstream, which operates at like the meso level, and that's at the community neighborhood. And examples of that are things such as housing quality, local economy, food availability, transportation. And then downstream is where we're usually working, right, in the hospital as we work with our patients. So the patients, individuals, and their families. And this is then things such as family stability, the socioeconomic status of a family, housing stability, things like that. So this slide kind of tries to highlight sort of the differences of the different levels of the bigger community society down into like our actual individual patients that we see every day. This slide is, I like to include because it kind of makes us remember, right? Like this is a framework and this discussion, right? This is not one talk and now we're good, right? It's lifelong learning that we have to do in this area, right? So for health professionals, if we want to understand and really address these issues, it's lifelong. And this graphic kind of shows us it's not just us working as residents and doctors and students, right? Like we have to work with, you know, the community, with organizations, right? Like, so you can see how it all goes together. And so this slide kind of highlights that, you know, generating awareness about the root causes of ill health and how we can address them like together, right? Like it's really gonna not be possible if we're trying to do it in silos. This I thought was fun and I wanted to include it to just make you smile for a second while we talk about all this heavy stuff. So when thinking about surgery, right, these I've highlighted here some examples like under geography or under economic. For anyone here who's interested in pediatric surgery or being a pediatrician, like a very striking one there that you could see in the middle, that the single most predictor of injury in children is the socioeconomic status of the neighborhood. That's obviously striking and depressing. And even though we have, right, like the social determinants in that definition, they're in different balls around, and in here they're in different categories, but we have to remember that each of these factors independently affect surgical morbidity and mortality, but they're also like closely linked and deeply intersectional. So for example, female gender has been found to be an independent risk factor for morbidity after lower extremity vascular operations. But it's even more pronounced risk in women who are Black patients. So hence the intersectionality piece. This is just to talk about what's happening here in our country. I mean, I think when we're in med school and residency and fellowship, right, like we often don't think maybe about, you know, places around that have no access to us because we are in our academic centers and hospitals. And so we do have, you know, everyone is coming to us having access. But if you look at the counties that are the, you know, wealthiest and the poorest in this country, look at the difference in the number of surgeons and the number of surgeons period, and the number of surgeons per 100,000 people. It's really striking, right? Like 50 surgeons compared to 5, basically. So 1/3 of US counties have no surgeons. So, you know, surgery is not a luxury. It is not a specialty. It is basic healthcare. So that 1/3 basically is about 10 million Americans who don't have access to us. So they're kind of like surgical deserts, mostly of course rural, but yeah, still swaths of the country where they don't have surgeons. And so then you'd think, okay, well, if I live in a city, I'll be better off because there's hospitals there. And this slide is just to say, no, you're not. You can have issues, disparities can be anywhere, whether you're in a city, whether you are rural, there are different maybe disparities or different issues, but no matter where you are, there's issues, right? So urban disadvantage, a term to explain or to comment on how people will come in with late stage cancer presentations. But then if you're rural, you don't get referred as often for surgery, you know, so wherever you live, there's definitely still issues. So something to be always thinking about. As a trauma surgeon, of course, I think about trauma. Despite gradual but continuous growth of trauma systems in our country, you could guess that the purple is the trauma centers, and look at how many areas in the country have no purple. And there's lots of data showing, of course, that if you are injured, you getting to a trauma center is really what is needed, because if you don't get to a trauma center, within a reasonable amount of time, which time is of the essence, you have increased morbidity and mortality. So in this case, 45 million Americans do not have access to a trauma center, and that includes helicopters, and that's within an hour of a level 1 or level 2 trauma center after injury. And we do have to bring up ourselves, right? Like, are we part of the problem? And of course we are, right? Like, how could we not be? We're human. So, the idea of social categorization, like, is there potential for us to categorize patients and then therefore change our recommendations? Whether it's conscious or not, it still happens, right? So there's been studies on this. Studies have shown that the implicit bias of us as surgical providers may negatively impact patient communication, clinical decision-making, and basically outcomes. And then a study showed that Black patients with a small bowel obstruction wait longer for surgery than white patients, and are more likely to undergo an open operation rather than a laparoscopic operation. And that's, of course, even when controlling for all the clinical variables that you need to control for. So we have to, think about that and discuss this as providers, that, where are we contributing to this? So, this is multiple components that can lead to these disparities in the care of our surgical patients, some being cultural competency, language usage, unconscious bias, all of that. Providers, we may feel uncomfortable or poorly prepared to address social risk factors. A lack of education on our parts has been well established as a source of healthcare disparities among minority populations. Formal training in cultural competency is uncommon in postgraduate medical education, and significant proportions of medical residents report that they lack confidence in approaching cross-racial patient encounters. So the American College of Surgeons has an initiative, Strong for Surgery. And I put this here just to show, hopefully, like, maybe people are catching on, there's hope. But if you look at this slide and what they're talking about here, surgical readiness and recovery, and they're, commenting on how these 8 areas are things that need to be understood and managed to really, have the best outcomes for our patients. But if you look at these and analyze them through the lens of social determinants, it really shows, some future directions for research that we can pursue to, account for a patient's kind of life circumstances. So we need to foster inquiry using community population-based methods, as we have an opportunity to impact the health of populations and healthcare on a broader scale. Still Matisse. I just have a couple slides on global surgery, because of course that can be a whole talk in and of itself, but I just wanted to comment on it a little bit. This slide giving you a sense of what % of sort of disease or globally is attributed to surgical disease, which includes OB-GYN as well, right? And the anesthesia component. So it's like all of that together, and that's about a third. So let's think about, could we, have universal access to safe, affordable surgical and anesthesia care when needed? Wouldn't that be great? So similar to the slide I showed about the different counties and the wealthiest and poorest, this is similar here, showing, countries that are wealthier, countries that are poorer, and kind of looking at the difference in the number of surgeons and operating rooms in these different places. So 14 operating rooms versus less than 2. for every 100 American surgeons, there's one African surgeon. So really striking, not surprising when you look on the map of, where in the world are the places that do not have access to surgery, and surgery that's safe and affordable and so forth. And there is a paper out about global surgery, which did a nice job of the Lancet Commission commenting on sort of some key messages that they wanted to get out. And one of them we already talked about, which is how many people don't have access to us, which is 5 billion. The message number 2, like how many procedures would be needed if we were, fair and gave everyone who needed one a procedure. That's 143 million. Then there's the piece of, people sometimes do get access to us, but then the cost of it is catastrophic, right? We've all heard about people having, to declare bankruptcy because they're like trying to pay their medical bills, both in this country and also, globally. And I think, key message number 5, right? Like I think people used to think surgery was like separate from health. It's like, no, like you cannot be healthy. You can't be a healthy person or a healthy community or a healthy society if you don't have access to surgery. And I think we know that maybe because we are surgeons and we feel it, but it's true that it's really an indispensable part of healthcare. So these were the kind of 5 key messages from this commission, which had people, representatives from many countries around the globe, contributing to this paper. So I am, of course, arguing that if we don't do something, generations will still have the same problems that we see now, right? Because we have to basically address the underlying causes of disease. Traditional medicine has not been proactive in addressing these root causes of surgical inequity and healthcare disparities, but instead we've really been reactive and we treat the downstream effect, which is acute disease. So if we want to make a greater impact on the health of our patients and communities as a whole, we really need to set a higher bar. We need to shift from a charity model to an equity model as we work with communities that we serve. So now I'd like to talk a little bit about this idea of, what do we do? What can we do? What should we do? And I think we should be, of course, active and involved in efforts and advocacy for social change. If you look at various organizations, they almost all, I think, really at this point, have these sort of declarations and so forth of responsibility. So the concept of social responsibility in surgery has deep roots in medical codes of ethics, and it has evolved alongside changing views on human rights and the role of social factors in disease. And I just picked 2 here. There's others, but these were just 2 that I highlighted. And this is interesting because we don't hear the word agency, I don't think, that often, but that's kind of what we are doing when we're working for and with our patients, right? Like to get them what they need in the hospital or when they leave the hospital and go home. So that's working on the behalf of our patients, which is wonderful, of course, but we're working within the system that we have. If we want to do something more, that's activism, right? Because now we are trying to change the conditions that affect the health of our patients. So agency, working within, activism, changing. The ethical duty of the surgical provider to society on sort of the ethical principles of like benevolence and justice, that is grounded within a framework of a social contract. Interesting, I'm sure many of you here who are either med students, do volunteer work. And when you look at who does the volunteer work, it declines during clinical training, right? So people are doing it earlier on and then it declines. So is it that it's because we're busy as residents and fellows working lots and lots of hours, so you can't, sort of do volunteer because you're already exhausted from just doing your paid job? And is it possible that the volunteer work that everyone did do as med students was not really a true social commitment? They were just doing it to get into residency or something like that. That's very cynical. I don't think that's the case. I believe the opposite, which is on the other side of your screen, which is that trainees do have a true social commitment. The fault actually lies with us. Us meaning medical schools, residencies, faculty, accrediting bodies, the big us. The fact that the sort of volunteerism and all that declines, that does not have to be the case, right? We can have a socially accountable curriculum. We can bring advocacy training into our residencies and medical schools. As faculty, we can provide mentorship sort of in this space. Through education, we can empower surgical providers to advocate for their patients, address the causes and consequences of surgical disparities, and incorporate social responsibility into their daily practice. What can you do? If you're one person, if you're a group of people, if you're a surgical resident, a med student, a hospital, like what can you do? So as an individual, here's some things that you can do. There's of course more than this, but I just put a couple things down. But these are some things as just an individual and not as a surgeon or surgical resident or a med student, right? Like just as an individual in society, like who lives here on this globe, this is something you can do. So that's as an individual. But if you want to sort of do something more, this is where we came up with kind of the idea of social responsibility, meaning SRS, socially responsible surgery. So we think of social responsibility in medicine as actually the professional duty of physicians to improve health of our society, right? Like we took that oath. So this also means that we should be diagnosing causes of disparities in health outcomes at the individual level and the community level, and more important, right, provide local and systemic interventions. Social responsibility is multidimensional. It involves political advocacy, community engagement, research, education. And I would say that it needs to be integrated into everyday surgical practice. So SRS as an organization was really a grassroots initiative when it started in 2014 with a group of people. Actually, it was myself and a group of 5 med students. So for any med students in the room to show like how much power you actually do have, it's pretty incredible. So don't underestimate your power ever. It started as like in the living room, eating pizza and drinking wine. And now 9 years later, there are chapters across the country with lots more coming on board. And I wanted to end, I'm ending, so hopefully people are still with me, but to give you ideas of sort of how would this work, right? Like it sounds great, like I'll be socially responsible, but like, what does that mean? So in our institution, I come from Boston Medical Center, and we are a safety net hospital, which is defined, by the way. You don't get to just say you're a safety net hospital. There's a definition for that. And so part of the definition is here in the sense of like what % of your patients are underserved. And as you can see, the majority of ours are. A third of our patients, English is not their first language. So these ideas of everything I've been talking about, it kind of works well where I happen to be working, which was a nice sort of circumstance that they go together. So one way to confront and sort of influence these root causes is through research. So we as surgical providers, we could, foster inquiry in different ways and reframe the questions that we seek to answer, and we can construct our research in a fundamentally different way. The new research, like as we think of this new research, it can still benefit our patients, of course, as it always has, but at the same time, hopefully, right, it enables us as surgical providers to advocate and actively influence change in policy at local, state, federal levels. So this is just some of the papers we have done or research we have done as SRS. This is one of the most recent papers we did that I wanted to just talk about for a minute, because it's something I'm very passionate about. Being I'm a trauma center who sees a huge amount of victims of violence, and the tragedy of that is not lost on any of us who do the work. So sort of medical and criminology, like literature, largely has focused on individual attributes to explain firearm homicide victimization. And that's often based in racialized stereotypes, right? Much of the medical literature is, looking at childhood behavior. Oh, is it poor parenting? But in recent years, we started to shift, right? So now we know what, and talk about redlining, like what is redlining? And these were practices in the 1930s, so almost 100 years ago already. And that maps were created that assigned different levels of risk to urban areas, defining which areas would qualify for federally backed loans. Areas with a high percentage of Black residents were considered hazardous and then did not qualify for these loans. So these are, of course, racist practices. They have significant downstream effects because all these years later, right, they're still enduring today because there's a profound wealth gap between Black and white residents. Recent studies in Philadelphia and Boston have shown this, that in redlined areas, you have higher rates of firearm violence. And what we did was looked at social mobility, right? So saying, okay, in poor areas, there's higher violence. And we know that the areas are poor because of redlining. And therefore, there's like discriminatory housing policies that were occurring. And because of that, there is no way to have economic mobility. But if you look at people and give them economic mobility, then the incidence of firearm violence changes. So kind of ending here with the advocacy piece, right? As we do studies like that, we then need to keep advocating. We need to, right? Because like there has to be action. It can't just be like, oh, it's nice, you have a paper on your CV. Like, no, that's not the point of the paper, right? So, interns and residents are coming into their training with a broader perspective of healthcare for sure than ever before. Because the view, I would say, right, is like wider and more socially conscious. Surgical educators, I think we have to acknowledge that the service and commitment to social change that we talked about does not have to decline during our clinical training. We need to show residents as faculty that there is mentorship regarding these ideas of social determinants and so forth in relation to surgical patients. And there was an Institute of Medicine report back in 2016. And the quote is that to impact health equity, it requires more than just accruing knowledge. Health professionals must develop appropriate skills and attitudes to be advocates for change. So the SRS effect, trainees realize that this is doable. Institutional surgeons, are now invited to the table. It used to be only pediatricians, right, and primary care doctors that talked about this. And as a surgeon, if you talk about it, they think you're wonderful because they have such low expectations of us as surgeons, which is unfortunate, but I can't blame them. So, if you can sort of be in this space, you have more opportunities to collaborate with others. Really, right, the new frontier of modern surgical care is ensuring that not only that we deliver excellent patient care, but we really do it in a way that's equitable and sustainable. We have the power to enlist support from institutions, from government, incentivize time dedicated to addressing the social needs of our patients. We must aim for innovative programs, curricula to train future surgeons in social responsibility and basically raise the bar in the delivery of our care. And I end with this slide, which is one of my favorite quotes, because I think it is absolutely the case that we can change the world. Surgeons, we can help lead the way. We can do things differently, and we can do things better. The greatest barrier is changing our mindset. And with that, I want to thank you all for listening. Hopefully you're still awake and engaged. And yeah, so happy to sort of meet you all and talk about this, and look forward to some good discussion.
Thank you so much, Dr. Dechert. That was a great talk. I really like ended with, I mean, you start a small group of medical students, as you said, and you're impacting the future careers of a lot of different people, including me, and hopefully including some of the people in this room. So thank you too. So I just want to start with kind of some of your guys's pre-submitted questions. I'll start with one. It's kind of a long question, but I'll try and shorten it up to what I think you're asking. So physicians are the gatekeepers of scientific information and are often the first to see what's impacting communities, giving the example of like an uptick in fatal gunshot injuries, for example. So as surgeons, do you think it's not enough to be able to not only do great surgeries, but also effectively communicate what we are seeing to policymakers and public health officials? So that's kind of the first part of the question.
Yeah, that's an easy one, right?
Yes, right.
I mean, I think I touched on this somewhat, right? Like, I think using a social determinants framework, right? Too often in the past, we look at the individuals and forget about kind of the societal piece of that. So although efforts towards individuals is necessary, I'm not saying that's not important, but these interventions are not really sufficient, right, to really address kind of the midstream and upstream determinants. So it gets back to those ideas. So then, yes, I think, as surgeons or as providers or whatever field of medicine we're in and how we're working, because we are on the front lines, right? Like, who knows more than we do, what gun violence is really like, right? Like, not the politicians, it's us who are taking care of the patients and working in these spaces, and us in the broad sense, not just doctors, right? Also social workers, like, all of the allied health professionals. I'm not trying at all to make it just medicine piece, the whole piece, the big piece. So yeah, and we, I think, should also recognize that we're not enough, or that we don't know as much as we think we do, even though we know so much. But like, right, like, there's community health workers are a big piece of, doing work with community engagement, because community health workers are trusted members of local communities, and they share essentially the lived experiences, right, which we do not. So we have to appreciate that, right? Like, that no matter how much we care and how much work we want to do, we don't share the same experiences, as people who are in neighborhoods and their peers and so forth. So working with others in this space is important, because they can help, as patients try to navigate complex systems of care. They can kind of serve as a link between hospitals and academics and the healthcare system, and more like community-based services and so forth. So yeah, I guess that's one piece of an answer for that.
Yeah, and I'll actually bring in a different question at this point, because I think you brought up a point of kind of community engagement. And one of the other questions someone submitted was, what are some strategies to engage with and listen to local communities to make sure that we're optimizing trust in these communities and understanding, so we can make an impact?
Sorry, I'm just trying to get you all back because my system was acting funny and I want to see you all. Okay, sorry. So can you say the question again?
Sure, of course. One of the questions was, what are the best strategies to engage with and listen to local communities to ensure surgeons are optimizing trust and understanding to make the best impact?
Yeah, that's a tricky one. I actually want to write a paper on this, because I feel like, not that I have the answers. If I write the paper, maybe I will, but like, how to do community engagement, right? I mean, historically, that's not what surgeons have done. So that's why I think there's a lot of really great surgeons who want to do it and they don't know how. And I think, of course, you have to have trust, right? Which is huge, right? Like, how do you foster trust when there's been obvious disparities for decades, right? And mistrust of the healthcare system, as there should be, right? There's really good reasons that people should not trust us. So how do you kind of get that trust? And I think we have to engage partners like within like community leaders and, you know, people who can be trusted kind of messengers in these various communities, recognizing that that isn't necessarily us because we are not, because we are part of the medical system. So we're automatically kind of, unfortunately, have a lack of trust. So I think it is recognizing our limits, recognizing that we don't know as much as we think we know. We need to learn, right? Like we need to learn. Like we don't know, we know somewhat maybe what communities need in the sense of like, oh, I'm seeing this trauma and I know this is a problem, but like, it's not, I still need to learn from people in the community what they need, right? It's not just like coming one way.
Yeah, and you do it naturally when you say community engagement. I just wanted to kind of make the point that I've heard in a lot of these talks is that using the words community engagement rather than, community outreach per se is good. I mean, you're saying, we don't know more than you necessarily. We know different things and we have to engage with you, not necessarily like we're reaching down to pull you up and help you. Like we need your help too. So I think it's important to use that language. To go kind of back to the first question, the second part of their question was that we often see gunshot victims return with their gunshot wounds, like, recidivism. Do you think we should advocate for these victims to undergo mediation or de-escalation training, like some sort of intervention? Do you think that that should be part of the treatment?
I think, which I didn't get into in this talk, because I could obviously go on forever on these like topics, but trauma-informed care is a whole other area that we could talk about. And I think when you approach it in that sort of manner, trying to think about, the history of the patients and what they're bringing to this whole experience, and whether it's like an inpatient admission, the trauma and our live experiences and what we bring to it as well, right? Like many people have history of trauma, not just the obvious, like, oh, trauma, like car crash, like that trauma, right? Trauma. And it all is with us and we bring it to these experiences. And I think, unfortunately, that's not just an answer necessarily for everyone. Maybe it could be a piece of one, but we have to come to understand really what's happening and do it in a trauma-informed way, right? Like if you put people in situations where they have minimal alternatives of ways to act, things to do, places to go, whatever, and then when they act in those certain ways that you so almost like predetermine people to act because you put them in these circumstances, and then we act like we're surprised or whichever, that they're acting in ways that anyone would act if they were in those exact same situations, right? Like, so it's complicated, I guess. I think as providers, if we come thinking that it's just, an individual is violent, then we're missing out.
The whole point, right?
Yeah.
Agreed. I like this question. How did you decide on your specialty and what makes this career rewarding for you?
Oh my gosh, I was just talking about this today. Trauma, not like I want to make you all trauma surgeons, but if you want to be one, that would be great. I am passionate about, and I kind of, I guess, have been for a long time, like social issues. Partly because myself, I'm a fly, which I don't know if anyone knows that term, like not FLY, that's a different kind of fly, FLI, which is first generation low income. So I think for myself, I have come from place like, I feel passionate about like people who work hard and like blue collar workers. Like that was, my parents, like they weren't educated and we worked really hard and didn't have much money. And like, so like my path probably predetermined somewhat, like that I can relate more to, the people who work at the hospital. Like I would prefer to hang out with like the maintenance guys than other surgeons, because they're like real. And like some of the surgeons could be, not in my hospital, but surgeons in general can be, whatever. Okay. So So then when you take social causes and put it in medicine, like trauma is just a natural, like, oh my God, if they go right, like public health is trauma, like it's absolutely. So I get to do work. So I get to be a trauma surgeon and then talk about all this, right? Like, and it's part of my work. So how wonderful is that? Like it's just wonderful. I like having kind of a cause, right? Like I want to feel like I'm able to not just, yeah, I don't know. Like, I don't want to pick on, like endocrine surgeons. I mean, thyroids are important too, and parathyroids, right? But like, right, like what's your cause? Like, I guess you're treating cancer and that's good. But I don't know. I want a bigger cause.
Certainly. Your message really resonates because I switched from plastics to trauma for literally that reason. And the second that I switched, it felt so right exactly for all the reasons that you've said. So yeah. Another question here. What key messages should surgical researchers remember? So how do we basically conduct research in a socially responsible way?
Oh God.
That's a big question. It's a big topic.
Well, yeah, like one piece of it is just how do you get people who are in all these different communities involved in studies, right? So that's one piece. So that your population studied isn't like homogenous, and then of course people of different backgrounds, cultures, races, right? They're not going to want to participate given the history of things we've done to people. So that's just one piece of research, like how to try to do better in that arena. And I think we're doing better with the research piece in the sense of try to always be thinking like, what is the point of this paper or this data? Like, it's not just enough to have data, right? Like, how are you going to change whatever system that this data is relevant to? So in your discussion of your paper, and then ultimately, right, like take your data and you go to the State House and you go somewhere, right? And you're like, this is not okay. And like, how are we going to fix it? So you put it in your discussion of your paper, and then you take your data and you like keep going. And you can ask questions in such a way that you then have things to act upon. And I'd say that's the key piece is turn it into advocacy, not just sort of research.
Yeah, I like that. I always hate when people are always talking about the problem. We know there's a problem, but the what now is what interests, I think, a lot of us. To follow up on that question, something I've kind of struggled with, and I wonder your thoughts on race reporting in research. So when we recruit all these people, we try to have a diverse study, and that's a good thing inherently. But then when we're talking about kind of biologic determinism, right, and genetics, like the genetics of race and that whole argument with the history of eugenics in the country and the world, like how do we kind of reconcile both of those things to not kind of reinforce harmful thought processes, especially, like when we enroll Asian categories, and obviously the Asian category is like a million
right.
like ethnicities, right? So how do we reconcile the importance of collecting race in surgery with also all of the issues with the way that we report who we are demographically?
Gosh, yeah, lots of easy.
I don't have the answer.
But I do think it does come back to that community piece, right? Like having patients involved in research, like in research studies, in design of the study, right? Like if you can engage with patients to be involved, not that they're gonna be researchers literally like doing data extraction and things, right? But you can have patients involved and kind of patient sort of advocacy panels, so that realizing like, what, I don't know how to maybe talk about this or research this in a way that I'm ensuring that I'm doing it right or, the most appropriate, and can you help me? So maybe that's a start. By no means the answer, but maybe that's a start.
Kind of the last of the submitted questions, and then I'll kind of open it up to anything that's come up in your guys' mind, is how do we get involved in SRS?
Oh my God, you can answer that question.
Yeah, I can, but
you or Kara can answer that question.
Certainly. Sure. I mean, I can answer the question, but you know.
Yeah, I've been talking enough. You answer the question.
Okay, so yeah, so Kara is amazing. She's one of my co-residents and went to Boston Medical School and then brought SRS kind of to UC Davis as the second official chapter. And then there was a couple of other UC Davis SRS members on that just logged off, but kind of started SRS at our institution and really defined all of our careers, right? And now I think I don't know how many active chapters there are, but I know that either active or in the process of being active is almost 30 chapters, I believe. So that's an incredible expansion. I was just talking to Lamario earlier today, and he mentioned that UAB is basically submitting an application for an SRS chapter just based on a conversation that we had when we were talking about inviting Dr. Dechert to this talk tonight. So that's how kind of quickly you can, you know, decide this is something important to me. This is something that I think our institution would benefit from. Like, reach out to us and, you know, get a couple like-minded individuals together. You don't need 50 people. You just need, you know, we at UC Davis really started with they started with 2, and then it really grew to like 4 really dedicated residents. And now it's grown a little bit bigger, but it doesn't have to start huge. It can start with just you or just you and a colleague reaching out to SRS. And then just to say a note that SRS is actually expanding on the national stage right now. And so kind of trying to become an institution that can connect the different chapters across the country and maybe in the future lead to national meetings, lead to submitting research in this area. So it's really, really exciting. It's a really exciting time to get involved. And again, I would suggest if you don't have a chapter at your institution to maybe put out some feelers and get some like-minded individuals together and just reach out to SRS and get it going. Love to have you. And that's all. So does anyone have any questions? Because, you know, there's only 14 people actually left. So I probably will just leave us in the same room, but I'm going to open the floor up.
I have a question.
Yeah.
So I'm really, really impressed. In fact, I had started, I'm the one that asked the questions about the penetrating injury in the returning patients. So I just matched in Oregon, and I kind of preemptively already started some groups and things like that because the level of gunshot wounds during my trauma rotation really, really like resonated with me, and I knew I had to do something about it. So finding this organization is just, you know, the chef's kiss. So I'm curious, is there like a group me that you guys have? Do you guys have some sort of communication tool with which you stay in contact with each other? Or you post articles and things that resonate with you, training, anything? Is there any kind of like that?
We're getting there. Yeah, that's our goal for sure. I'm lucky that as a trauma surgeon, I do work like as a faculty trauma surgeon. You know, I'm in like the committee on trauma for the American College of Surgeons. So then I'm doing work there in a committee about attenuating violence through social determinants. And so I can like take that work and then bring it to my SRS group. And then like, you know, like, which is helpful because there are other people, of course, out there, you know, doing great work and trying to connect all of us. So I think that's the key, like in the sense of what you're bringing up, right? Like to not be siloed, to try to make sure that we all know each other and we're helping each other and supporting each other. And so the best way to kind of get all that word out, it's hard, right? But I think somewhat it might still be med Twitter despite recent events with a certain individual. I don't know, but I'm because I've found that a lot of opportunities for SRS and this type of work came through there, you know, like people reaching out and saying, hey, let's, you know, do you want to give a talk on this? And do you want to collaborate on that? And so, right, to find each other can be hard, but think about too, like different national organizations are much better at this than they used to be. So what the American College of Surgeons is a little big, so that would be hard to maybe like, but smaller like surgical organizations and societies have different committees that are involved in this work. So I would start checking into the different surgical societies that interest you. So if it's like smaller ones too, like I'm involved in the Association of Surgical Education, then there's like Association of Asian Academic Surgeons, there's Association of Women Surgeons, there's SFAS, Society of Black Academic Surgeons, there's the Association of Allied Surgeons, right? Like there's a lot of these different groups. They're not doing the gun violence piece specifically, but just, the more like things related to all of this, like disparities and equity and, in general. So there's a lot going on out there, and just reach out to people, honestly. Like, you don't have to know people. If you just email someone or DM them, they'll just be like, oh yeah, because right, like people who do this work love to talk about it and to talk with others. So be out there, like just go for it.
If there isn't already a chapter in Oregon, I'm going to be starting one. So I will be stalking you all.
There you go. There you go, get it. And, Dr. Dechert spoke really well on your question and kind of how I had brought up the coming national SRS organization comes out of everybody kind of saying the same thing that you just said, right? Is there a way for me to just be around you guys all the time? Like, I just want to be around you guys all the time, right? So keep an eye out for that stuff, especially if you start an SRS chapter, you'll be kind of looped into all of that. Sophia.
Hi, thank you so much. It was really informative and I really appreciated your talk. My question is there like a way to get involved with this at the undergraduate level? I'm currently a second year and I'm really interested in starting something like a chapter before I leave for study abroad. And I just wanted to hear your opinion.
Wow. 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 I don't know. Like I almost remember being an undergrad. I guess I was one time. That's so long ago. Yeah. How are we going to get undergrads?
What's your medical school there? Do you have an attached medical school?
No. So actually, I go to a liberal arts. It's called SoCA University of America. And Jacqueline Mills is the pre-health advisor for us, and she connected. Yeah, so like we don't really have an affiliate, like we don't really have an affiliation with the medical school. So I'm trying to like do something here.
I will just say that with the National SRS organization, which I really do think it's going to be up and going soon, there is part of it where you can apply to SRS as an unaffiliated member of SRS. So that might be a future way to get people involved that aren't necessarily medical students or residents at an actual institution. You could just be an individual that's part of National SRS and then can still, come to the national meeting that we eventually set up, be involved with all the communication. I think that would probably be the best way, Dr. Dechert, if you have additional thoughts.
And I didn't mention this, I probably should have, but like SRS at different institutions, it's not just residents and students, and it's also like ours, we have nurse practitioners, we have social workers, we have others. And I know that's true in other chapters. So it's not as if you have to be a med student, or you could be you or various professions or allied health professionals, whatever, right? It's just basically anyone who cares, right, about these important issues.
Thank you so much.
In the meantime, Sophia, like if
okay, yeah.
In the meantime, like Dr. Dechert said earlier, just reach out. You could always hop on research or something. I mean, it might be convenient if you have a close. Where are you located geographically?
Southern California, like kind of like we're close to UCI. Like I could drive there. It's like 50, and then like I'm from San Diego, so I could also I'm close to UCSD, so I don't really know how like it works specifically, but yeah, so
that's how it works, right? You find
a
place that you're close to. I talk to med students all the time and college students all the time that are kind of wanting to get involved in research, right? And it's not hard. It can happen. You just reach out and you say, hey, I'm interested in this work. Are you interested in helping me with this research project? And a lot of students and residents would be happy to work with anybody of any level. You know, it's all about like-minded interests, right?
Thank you so much. It's really helpful. Thank you.
You can email me is what I'm saying.
Okay, perfect. Thank you.
And Sophia, there's a big conference of surgeons coming to the San Diego area in mid-April. So if you want to, I'll send you my email, but if you'd like to meet, I could connect with people in your area or give you my email at least to connect here. So,
That'd be
and
awesome.
anyone who's interested in joining, like there's SRS people all over the country. So it will just connect you to the right people. If you, we'll give you my email on the chat, and then hopefully we can meet up in like the mid-April time.
Oh my gosh, that's so awesome. Thank you so much. I would love that.
Of course.
Thank you.
Megan, would you like to introduce yourself, given your significance?
I'm Megan. I'm
Over
one of the
here.
co-founders of SRS. I've worked with many of these people, Jackie Bills. I've worked with Kara. I've worked with Dr. Dechert. I'm at the University of Michigan right now, but I'm going back to Boston Medical Center in the fall. So I've kind of been all over the country and worked with lots of different amazing people, and it's a great group. It's just wonderful and supportive, and whatever you want to pursue or whatever your interest is, and kind of forwarding surgical care for people is our mission. And just helping us all organize together and making this an efficient process, I think, is our goal. So whatever we can do to have people join that and to make more equitable surgical care, I think, is like our big drive. So I'll put my email in the chat, but if anyone wants to shoot me an email, I'm always available to talk or whatnot.
Thank you so much for sharing. Thank you.
Nice to meet you all today.
Nice to meet you too.
So it's so long ago that we started SRS. Megan was a medical student and she's now faculty in a couple months. So that's pretty crazy, right? Yeah, that's pretty
So
crazy.
you're going back to Boston as faculty then? That's really
Yeah, I just can't stay away. It's a wonderful place.
that's amazing.
In trauma, of course.
Of course.
Oh man, wow. It sounds like an incredible place, to be honest. You know, it's interesting to talk with people from Boston, and then it would just be cool to be in an institution where it really seems like a lot of people support this work and there's quite an infrastructure for the work. So hopefully more institutions will become that over the next couple of decades.
Yeah.
Does anyone else have any questions about the talk or specific questions for Dr. Dechert? Otherwise, I'm just going to have everyone introduce themselves and like say, what drew you to coming here, and if you're working on any projects of interest or whatnot. So, but we'll finish questions first. So
Sorry, I have another question. I was the one that asked about like why you chose like this specialty. And that was really helpful to hear your response. But even if like, I'm still like, I don't know what I want to do yet. So I'm like, how can we like do this? Like, how can we implement these ideas and like across the, like make it like larger scale and not, I mean, I guess, I don't know what I'm trying to say, but like, I want to be able to like implement this philosophy like in any specialty that I go into. So like, how do you kind of suggest like doing that?
Kara, did you want to say something? Because your light came on.
No, I'm just listening. I'm just also happen to be on trauma call right now. So I'm like,
I think, honestly, the whole grassroots piece, I think that's what you do. Like I had these crazy ideas, which of course they're not crazy, but at the time people in surgery thought they were crazy. And I was like, all right, well, I'll find people who understand and agree. And like, I found med students, and of course, Megan and the group, which I'm still in touch with them all, and they've all become trauma surgeons. So it's fucking awesome. Oh shit. So it's awesome. Sorry, as trauma surgeons, we curse a lot. Right. It was like, find people, like find your people, just get out there and like do the grassroots thing. I mean, I think that really works and can work. And then of course, like read and like, look who's out there saying what, this and that, and like try to see what's going on. But like in med Twitter, there's a lot of people who do work that's really great. And you can see kind of what they're up to. That's one way to kind of cheat and try to get a sense of who's doing different things too. But grassroots, I think.
Thank you.
Like Dr. Dechert kind of mentioned earlier, it wasn't until recently that surgeons were really asked to be at this table. And so when you say you want to do this kind of work across a broad range of specialties, realize that there are a lot of specialties, family practice, emergency medicine in particular, that do this work and kind of have been doing this work for a really long time. And then also take heart in the fact that even if you go into a specialty that hasn't been doing this work, that doesn't mean that, like Dr. Dechert said, you can't grassroots and create it yourself. So
Thank you so much.
anybody have any other questions? Dr. Dechert, did you have any closing sentiments or anyone else have any closing words?
Oh, it's just been great. I mean, I find, right, the work can be tiring and all that and frustrating sometimes, right? Like dealing with health systems and all the mess, but then like you do this and then it re-energizes you. And that's how I keep going, right? It's like talking to people like you guys and then seeing like, oh, like there's hope, right? Like people are starting to get it. And it's just so exciting. And I guess, please, like my last parting words, like, please just don't ever underestimate the impact you can have at whatever stage you're in. Like you have so much more power and potential to like have impact than you realize. So try to take advantage of that.
Awesome. That's a great place to end. So thanks everyone for coming, and I'm sure we'll talk to some of you soon. So.